Hi, everyone, and thank you for joining the Superior Health Quality Alliance Roundtable event. My name's Kim Heft. I'm joined by many of my colleagues. I'm not going to name them all, but we have Janae, Janeri, Constance, Mike Keisha, as well as our guest speaker today, Rachel. And Rachel, you know what? I forgot to ask you, is it Dibble or Dibble?
It's Dibble, Rachel
Dibble. Okay, and welcome, Rachel Dibble. Give you a little background. We host these 1 hour sessions on the second and fourth Wednesday of the month. The first half is a didactic presentation, and then the remaining time will be for question and answer. We're going to put the link for the PowerPoint presentation in chat momentarily, so you have that at anytime you'd like. Please use that chat box to share your comments, questions, anything that comes to your mind during the presentation, and we'll use that for discussion in our Q&A. I also want to put it out there. Don't worry, at the end of the presentation, if you don't want to type your question out or your comment, unmute yourself, raise your hand, and we'll give you the floor to ask your question or your comment. There's also going to be an evaluation link in chat towards the end of the presentation today. It only takes like about 30 seconds to a minute to complete. We'd appreciate it if you do that for us. That's all the announcements I have for today. It's a short one. So we're going to get right to today's presentation. It is the first of a two-part series on improving diabetes management and long-term care, actually based on a couple of evaluations that I was reviewing from the past, holy cow, 2 years actually. Diabetes management came up in a few of the requests for presentations. So here we are. So let's get started. And Rachel Dibble, the floor is yours.
Thank you so much. Welcome, everyone, and thank you for attending. My name is Rachel Dibble. I am a nurse practitioner by trade. Most of, or rather all of my is in chronic disease management, and then my specialty is palliative care and hospice. That all kind of goes with one another. So I have a lot of experience with navigating multiple chronic diseases, diabetes being the biggest one, I would say. So I'm excited about giving this presentation. I hope that you do have a number of takeaways. I know diabetes, we hear diabetes and we're like, oh gosh, diabetes again. However, CMS in particular, with a lot of their recommendations and literature that they have, there is a huge push in managing diabetes better and long-term care in particular. So this is diabetes part 1 of improving diabetes in long-term. And our second session will be coming up, and that will speak more to the coordination of care. So this is really just the didactic portion of diabetes. Next slide, please. So after attending this session, the objectives are to understand the pathophysiology of diabetes, evaluate who is at risk for diabetes, and identify signs, symptoms, diagnoses, and treatment of diabetes. Next slide, please. So to get an idea of just some base knowledge here, here's a polling question for us. So let me move my polling question so I can read the question. For a didactic person with good glycemic control, what effect does exercise have on blood glucose? A, lowers, B, raises, or C, no change? And I'll give you a couple of minutes to fill your answer. Okay, very good. And in the talk, I will give you the answer within the talk, but this gives me a really good idea. Thank you. Okay, next slide. So what is diabetes? We all know the basics of diabetes. I'm not going to get into like mitochondria and cells not acting properly, et cetera, but just the nuts and bolts so that we can understand how diabetes affects the entire body. And that is why this disease is so devastating, particularly for those that are unmanaged. So what we do know, of course, is that the pancreas secretes the hormone insulin. The insulin then carries the glucose from the blood and it pushes it into the cell. So the role of insulin is that it sees the sugar outside of the cell and it pushes it into the cell. And then once the glucose is in the cell, the glucose, of course, is converted into energy for us to have energy and more importantly for our brains. Glucose is what makes our brains work. And that is why diabetic ketoacidosis and hypoglycemia is so dangerous for our patients when that does not work correctly. Glucose remains in the bloodstream, which causes then the glucose to build up. And so what that means is either the pancreas has not secreted enough insulin or the term is pre-diabetic. So we've heard the word pre-diabetic or insulin resistance, often pre-diabetic. So insulin resistance, and when I was in nursing school, I would always get my hand slapped by saying pre-diabetic because back in that day, or insulin resistant, it was, you're pregnant or you're not. There's no pre-diabetes. That's changed now, thank goodness, because I think that helps providers detect diabetes. So insulin resistance, what it really is, it's a general term that means that insulin does not exert its normal effect in insulin-sensitive targeted tissues, such as your skeletal muscle tissues, your adipose tissues, your liver, your heart. And so when that doesn't happen, obviously the sugar does not get into the cell, then we don't have energy and it's hanging out in your vascular system. That's not where we want sugar hanging out in our vascular system. We want that sugar inside the cell. So that's kind of the down and dirty of the patho of diabetes. Next slide, please. So diabetes by the number, and this is again why CMS is raising their hand more so in really trying to identify diabetes early, because then we get into chronic kidney disease and end-stage renal, which is a major burden on the system, Medicare system. So if I look at diabetes by the numbers, from 2001 to 2020, diabetes prevalence significantly increased among US adults in 18 or older. So what that looks like is that 37.3 million people have diabetes, and that's 11.3% of the US population. That's massive because people who have diabetes often don't just have diabetes. Perhaps it's not well managed. And their vascular system, because they have sugar hanging out outside the cell, is getting, it's wreaking havoc on the vascular system. So then we have another 28.7 million people who have been diagnosed with diabetes. And then we have 8.5 million people who don't even know they have it, have no clue that they have it, that maybe kidney disease is popping up because of it. So if we look at it, just if we're standing in a room or in a restaurant, 1 in 5. So we have, I don't know how many people we have on today. We have 42 people. So if we just do that simple math, 8 people is what we're looking at in this room. So that's pretty significant presently. Next slide, please. So the total pre-diabetes. So if we add these numbers together, we can really see the escalation of this disease. So pre-diabetes, those are folks that have not been diagnosed or maybe don't even know that they're in that range. That's 96 million people in the US. And 26.4 million adults, 65 or older, massive, because 65 and older, we're also looking at chronic diseases with diabetes. So it's more complicated. And so that's 26.4 million of 65 and over. The cost of diabetes is horrifically expensive. Total estimated cost of diagnosed diabetes in 2017 was 327 billion, including 237 billion in direct medical costs and 90 billion in lost productivity, meaning people can't go to work, or coupled with their CHF and their diabetes, and it goes on and on and on. So if we add all those numbers up, I mean, I can do just quick math, and I'm looking at almost, $500 billion, 600. That's a lot. And so excess medical costs associated with diabetes were $9,601 per person in 2017. And that data is a little bit old because CMS is 2 or 3 years behind insofar as that data. So if we just look at inflation in the last 6 years, we can really see the fiscal devastation here. Next slide, please. So diabetes is the leading cause of kidney failure and new cases of blindness amongst adults in the United States. Diabetes is associated with increased risks, as we know, of cardiovascular disease. And the reason for that is we have all that sugar hanging out in our vascular system, and it is wreaking havoc: kidneys, liver, lung, brain, every system in your body. Non-alcoholic fatty liver. I see that a lot with folks who have metabolic syndrome, and that's the key indicator that you may be looking at diabetes, and I'll speak to that in a minute. Non-alcoholic steatohepatitis was estimated to be in the 7th leading cause of death in the United States in 2017. Screening asymptomatic adults may allow for earlier detection with diagnosis, treatment, and the ultimate goal of controlling glucose levels and improving health outcomes. And that's the key here. It's screening, screening, screening. And we'll get into who you should screen. Next slide, please. So who is at risk? The elderly, 65 and over. And they're in a whole different bag, really, of your 65 and younger insofar as diabetes, particularly because of their cognitive decline. Brain is atrophying as you old, memory loss, then you're looking at some diseases, Alzheimer's, dementia, potentially. So the elderly, massive risk. Obesity and overweight. I know we hear it all the time, but I want to put a big star by that one. If someone is obese or overweight, BMI greater of 25, and I know that chart's a little scary because if you look at it, technically I'm overweight. My doctor tells me to gain weight. So use your common sense here, but I'm talking about where a habitus is obese, very clearly obese. That is your first indicator of screening, because when you see obesity, you're most probably going to see your LDLs. Those are your lethal cholesterols. Your lethals are high. Your triglycerides are probably high. Your healthies are probably low, and you're obese. Ding, 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 and hypertension, diabetes. Screen, screen, screen. So that is your biggest indicator. The other, and I will go after this, I'll move on from obesity, is the body habitus. If it is apple-shaped, people are carrying their weight in their midsection. Right there, massive cardiovascular risk. And that's on a half-a-second assessment, right? People with pear-shaped, they carry their weight lower. They have risk, but not as high risk as apple. So just that image in your head, hey, we need to be looking at diabetes, hypertension, hyperlipidemia. And we could be saving lives because we have sugar that's outside of this cell, and we got to get it back in somehow. Gestational diabetes, any pregnant woman who has had that in the past at risk. Women with polycystic ovarian syndrome, POS, 45 years of age or older, first degree relative. Really look at that first degree relative connection. Physically active less than 3 times a week. The actual recommendation is 150 minutes a week. So however, you'll see them both ways, but it's 150 minutes a week, 30 minutes a day, basically. and then the history of gestational diabetes, non-alcoholic fatty liver, and then insofar as our ethnicities, our African American, Hispanic, Latino, American Indian, Native Alaskan American people, they are at higher risk. That's genetically, and that's also culture, diet, exercise, etc. So please be aware of these risk categories. Next slide, please. What are your screening types for diabetes? If your A1C is a great measure insofar as it is your 30-day mean. The recommendation does say you can diagnose on this. I like to diagnose on a fasting glucose level, and or your random glucose test in particular. Next slide, please. So you have your signs and symptoms. So urinate frequently. You're really looking for that thirsty all the time. And this is abnormal. This isn't like, it's a hot day and I'm drinking more water. This is, potentially gallons of water. I have seen that. And then we get into electrolyte problems. So we have to watch that as well. Hunger, blurry vision, numbness or tingling of hands or feet. That's where we're getting into those vascular problems, neuropathies, because your system is getting charred by those sugars. Lethargy, very dry skin, urticaria is what it's called. So when you're scratching and scratching, you're typically looking at chronic kidney disease, which then could mean diabetes. So so when someone comes in and says, I have just been scratching the heck out of myself, think about this, and their habitus is obese, hypertension. These are all of your red flags of start thinking down the path of diabetes and chronic kidney disease. Sores and healing slowly. Big. People with diabetes don't heal quickly. And so for the folks who don't know they have diabetes and they have the scratch on them that won't heal, you could be looking at diabetes, very big indicator. Infections, that sore gets infected, or they are getting sick more often and potentially not immunized. Fruity breath, that's a big one. We're in DKA, and that means we're hyper, and that can be very serious. And it smells like juicy fruit gum is what it smells like. So be aware of those signs and symptoms, big indicators. Next slide, please. So quantifying your diabetes diagnoses. So your fasting blood glucose, the cutoff is 125. So what that means is if you have someone who is 126, they are diabetic. They are not pre-diabetic. If they're 125, they're pre-diabetic. Your 2-hour fasting for your pregnancy population is 140 to 199. So if you're 200, you're diabetic. Or your A1Cs greater than 6.4 or 6.5. Hit 6.5, diabetic. But again, I really like my fasting glucose. That was how I was trained. It's what I'm comfortable in doing. Next slide, please. So here are all the treatments that I'm not going to go through and kill you with here. So when we look at treatments or anti-diabetic treatments, obviously we see this. We have our metformins, we have our insulins, our sulfonylureas, our SGL2, our GLP-1s, diet, exercise. All of these things are incredible and great. And depending on the patient's management plan, what kind of diabetic they are they insulin resistant? Do they need insulin, meaning their pancreas is not producing insulin, or they're producing insulin that's not effective? So these different classes of drugs do all sorts of different things. So basically a summary of these drugs and a takeaway would be that these anti-diabetic agents comprise a chemically and pharmacologically heterogeneous group of drugs. The objective in treating diabetes is to prevent undue rises in blood throughout 24 hours. It's as simple as that. We don't want these peaks and valleys. We want to keep people stable on these therapies. So the objective, though, is it is widely accepted that good control of blood glucose prevents the development of microvascular, that's what I'm talking about, the micro and macular, which is the retinopathy, neuropathies, and the neuropathic long-term complications of both diabetes type 1, type 2. So when we look at type 1 diabetes, that person, their beta cells and their pancreas, they're dead. They cannot produce insulin, not a chance. That's when you have the folks, the children in particular, is when you're diagnosed with the pumps, and now it's all automatic. It's made it much easier on children. However, what you do have to watch out with type 1 is your diabetic ketoacidosis. Getting up in the 500 and 600s with that patient, ensuring that they have enough and their monitor is set correctly. In type 2, a choice of treatments, including any of these classes that are up on the slide. So these comprise of drugs that increase insulin secretion, which are your sulfonylureas, your glipizides, like drugs, and drugs that improve insulin sensitivity. So those are your metformins. And then you have your other class of drugs that reduce, which are your GLP-1s, and that reduces the carbohydrate absorption. So that's what these classes of drugs do. I won't get into the detail of all of them, but that is the goal of these drugs. Next slide, please. So upon your assessment, what you really want to look to in your, particularly in long-term care, 65 and older, I would say, is that the factors that increase the risk of treatment associated with hypoglycemia. Hypoglycemia in long-term care is a big problem. I think you all are probably abreast of this as well, particularly those that are not cognitively intact. For example, they could have told the CNA they ate, or whatever the situation may be, they get their diabetic agent and they bottom out. Many a scenario, other medications, contraindications, etc., can cause hypoglycemia. A lot of this is caused by the food being put in the body, or the lack of food, put it that way. Or someone's been sick for a week, they haven't really eaten, but their diabetic agents have not changed or decreased, or we're not holding. So then we get into falls, and then we get into broken bones. And you can see how diabetes can really get you down on this very slippery slope. So the factors that increase, obviously, are your insulins. These are your long-acting insulins, typically not your rapid-acting. Frailty in the older age, as we know, old people don't have a lot of fat on them. That's what happens when we age. Cognitive impairment, impaired counter-regulatory responses with hypoglycemia. So like, I know when I get starving and my sugar drops, I'm hangry. I need to eat. Older folks don't have that sensitivity. Unawareness of physical or intellectual disabilities that may impair, say, intake. Behavior responses to hypoglycemia. I used to see often, even in the nursing home, perhaps security or whatever may have happened, that patient was drunk, that they had been drinking. They hadn't. They were hypoglycemic, and they're stumbling around. And so these are things we need to be aware of. Alcohol use, though, that will bottom someone out and make them hypoglycemia. We need to be aware of polypharmacy, big risk in our older population. ACE inhibitors, those are your angiotensin converting enzyme inhibitors. What's interesting, though, is that what we like to see CKD patients on with diabetes is 5 milligrams of lisinopril, which is an ACE inhibitor. That's a very low dose. That is fine. But when you start getting up then with your dosage, and then typically people have a number of hypertension medications on. They may have a beta blocker on, an ACE on. That's when you need to start paying attention for hypoglycemia. And then, of course, your impaired kidney and hepatic function. And all of this impaired, for geriatrics, it decreases. Kidney function decreases with age. So we got to really look at our older adults And then obviously folks who had a longer duration of diabetes, they've had more damage on their bodies. So we need to be aware of it. And lastly, history of severe hypoglycemic events. People who fight this and try to manage their blood sugar, it really is a hard task for patients to do this if they're not in a rhythm or regular routine. Next slide, please. So immunizations are of paramount with this population, with diabetes or any chronic disease for that matter, because their immune system is down. And so they are much more susceptible to these viruses. And in addition, typically you're looking at a number of comorbidities with the older patient and diabetes. So the CDC recommendations obviously are COVID, influenza. Influenza, we know, kills 40,000 people a year, particularly geriatrics, very important. Your pneumococcal pneumonia, your Tdap, zoster. Tdap should be every 10 years, by the way. Zoster, Hep B, and then your HPV. And I know in the older population, HPV isn't usually done. The guideline is 25 is the cutoff, and then it goes patient by patient of what they would like. Next slide, please. Patient-centered approach for diabetes is really, I would say, the biggest takeaway of this talk. And what that is really understanding your patient, their exercise pattern, their eating pattern. If they get sick and they stop eating because they just eat soup or jello that day, what they need to do with their diabetic agents. So the decision cycle for the person is really centered on glycemic management in type 2 diabetes. And it is a stepwise approach. So step one, assess the key person characteristics. So if your person, is Johnny on the spot and they came in with their journal, they tell you when they, take all their insulin and their anti-diabetic agents and you prick their finger 3 times a day, that guy is like really interested in managing this. And then you have the other guy that's like, yeah, I do it once a week. I'm not real sure. So it's then being an investigator, digging. What can I do to help you? Perhaps to understand how to manage your diabetes better. You've been in the hospital twice because of a hypoglycemic event and you broke your hip. So what can we do to manage that to where this doesn't happen again? So there are some of those ask, tell strategies insofar as when you're assessing and interviewing, and consider specific factors that impact choice of treatment. Honestly, a lot of this is financial. And that is something to be very, very sensitive to. There are a lot of programs out there that are covering, but it is a real pain point for our patients. Refrigeration, another pain point for insulin. Travel, coolers, they're expensive. So these sorts of really getting in the mind of your patient and what their life looks like to be able to manage this, and you help them problem solve. Agree on a management plan. Then I always would pilot it. Let's pilot this for the next 3 weeks. Let's see how it's going. Come back. And then we would tweak it. And I would work with the patient. Usually it wasn't a one and done. It was a process, probably 60-day process. And then provide ongoing support and monitoring of choices. And again, it's that conversation. This didn't work. Well, that didn't work. I felt I was getting hypoglycemic and I didn't have a candy bar in my pocketbook. Okay. Then what did you have at home that we could have substituted? Oh, I have a whole bunch of hard candy. Terrific. Let's throw that in there. They can be small things that we need to help people get in the habit of to manage their diabetes with education and understanding. And then review and agree on a management plan. This is really important to have tight reins on this and to support your patient. A lot of these patients don't feel well. They are overweight. There's a lot of psychosocial behind this. And when you talk to your patient, it is patient-centered. It's head to toe. You have neuropathy, so you can't exercise. It's all these nuances that happen with chronic diseases and diabetes being the chronic disease, and all the sequelae that have happened out of that. And so in being successful, it's that sort of detail with your patient and plan. Next slide, please. So takeaways. patient education and compliance. Diabetes is a partnership. And I say that from my experience, and getting people out of really potentially grave situations if it wasn't managed well. Management of glucose, really keep a log. My stepfather, who unfortunately passed away about a month ago, had a really hard time a number of years ago taking care of his diabetes. And just step by step, what was your sugar this morning? And then I go down and look at his log. He wasn't interested in doing any of this, but when I explained all of this and the importance, he got it and he was happy to do it. And he ended up being a wonderful patient, and managed his diabetes terrifically well. The other takeaway I will leave you on before we conclude is that I do want to mention two things that has come to mind. When you do put patients on metformin, if they are in this pre-diabetes phase or even diabetic, please, please, please ensure that with contrast, particularly your geriatric patients. If they're going in for a CT, they have to be off of their metformin. It will shut their kidneys down, kidney failure. I've seen it a number of times in the hospital, and there's big signs that say, make sure your patient's off metformin before you do this. Particularly with your geriatric patients, they may not remember that they're on metformin. It's that medicine that starts with an M, sometimes we hear. So we have to ensure that our patients are safe. And then I will leave you on with the geriatric patients and the tight control of glycemic. The guidelines, the Diabetic Association they've let go a little bit of the tightness because of hypoglycemia. They're seeing too much hypoglycemia. So your older adult, otherwise healthy, their A1Cs can go to 7, 7.5, and they are still within range, okay? We're not going to keep them at some 100, say, daily glucose either. We let them go a little bit into the 150s. There's tight guidelines, though they're concise around this. So no, 65 and under, you're dealing with a different set of guidelines and glycemic control than you are with 65 and above. So with that, I do very much hope that you have learned something and have a couple of takeaways, and leave you on the note, if you could please fill out the evaluation. We love them. They help us so much understanding what you need, and we're so happy to supply that. So thank you again. I enjoyed this very open forum here. Shoot out questions, put them in the chat, however you want to do it. We're here to answer anything you feel to ask.
So Rachel, we're going to go back real quick. Do you remember our polling question?
Oh yeah.
The polling question, like, what effect does exercise have on a patient, a resident with good glycemic control? Now, I'm going to share the results, but I wonder if anybody has changed their mind from their original answer. Are you seeing them?
I am.
Okay, good. All right. Yep. We have some smart cookies out there for sure, because we know that the answer is that
it decreases. So that's, again, in one of your lifestyle changes, which is your first intervention for that patient. This is your first visit. You notice they're pretty obese, they have hypertension, hyperlipidemia, et cetera, et cetera, et cetera. And then, when you prescribe diet and exercise, if they are on an agent, for example, they wake up, their blood sugar is 200. They take their anti-diabetic agent, we get it down to, say, 120. Then they go exercise and they haven't eaten. Then they go exercise. More glucose is getting pushed into their cell. And so what's happening, too much. And so what's happening then is their glucose, they're bottoming out because they haven't eaten and they're on their anti-diabetic agent. So what they should do is eat and then go exercise. So when that diabetic agent pushes, it has something to push into the cell rather. And so that's why people go hypoglycemic if they haven't eaten and they're taking their agent before they exercise. Or people can take their agent after they exercise. Exercise, take your blood sugar, then take your agent.
Yes, anybody has any questions or comments, please feel free. While we're waiting for that, you actually you kind of like struck me here. This is a great topic for myself. I will share with all of you that I have a daughter that is a type 1 diabetic. She was diagnosed when she was 9. She's now 27. And I'm curious for the audience out there, we see more and more people with insulin pumps or the continuous glucose monitor. These are things that are attached to the resident if you have a resident's body. But here's the thing. Do you have a policy for this in your home? I mean, how many people, if any, are coming to you on an insulin pump or continuous GCM? I'm telling you, because I remember when I was working in the nursing home, we had one and we never had one before. And you're like, uh-oh, how do we manage this? Now, it was a short-term care person was able to manage their own, but as nurses in long-term care, we really weren't very familiar with this. So I encourage you. I say encourage. I'm curious. Does anyone out there have a residents that are coming in with pumps? And if so, are the nurses aware? Not aware, aware how to, how to work them. Do you have a policy for this?
I can say in all of, I used to manage, I don't know, 28 nursing homes, and we did not.
Well, you can't say it won't happen though.
Yeah, but that's a great, you've gotten me to think. That's a great point. Never thought about it, to be honest, but we did not.
And I don't recall either being in a facility having a diabetic pump policy. But my real quick question is around when we talk about our population with diabetes, we have very strict guidelines around what we should do is very prescriptive from what the doctor has ordered. But when we talk about pre-diabetes, especially in long-term care, there isn't a lot of structure around that. It's just watch your diet, exercise, right? So how can facilities really embed best practices when we talk about pre-diabetic patients and how to navigate that so that they don't become a full-fledged diabetic?
Well, Makisha, I can just speak to the pre-diabetic patients often that I would see. We would start them on metformin because first and foremost, it is a great weight loss agent. But was there, it's diet and exercise when you're pre-diabetic. So that was usually what I saw in long term, because there's just not a lot of programs that could support that. That metformin causes also a lot of GI upset too, so that took staff away because of those problems. So, So Sharon, I'm reading your comment here about it'd be great to create a resource for creating policy. And maybe we'll look at, maybe we can help you with that. Maybe we have something, I am not sure. There may be some thoughts along that might be helpful.
Yeah, I'm wondering if you'll see Angie comments that they have a policy for their CGM and related education. But you're right, there's different types of devices. So I'm like thinking about just how you have your general policy, but then of course getting that booklet. Well, it's not a booklet anymore, but Googling that booklet, doing that, 10-minute education, with the nurses that are, going to be taking care of that patient.
And I've got a question for the audience insofar as hypoglycemia. I mean, do you guys see a lot of this hypo or any challenges, or what do you, I'm curious what you see in practice and what you see in your facility regarding diabetes and just in general. Nothing's too big or small. Yeah, much more. It is much more concerning. Absolutely. And I know you do. I'm just going to ask for the heck of it. And protocols surrounding that, glucagon, all that sort of. Do you have like standing orders, all that within your homes?
Yep. Rachel, would you still go by the what we used to call the 15-15 rule? If a blood glucose is below, well, you'd be in your policy, whatever the parameter is for that person, and give 15 carbs, wait 15 minutes, and recheck. Is that something that is still practice? You can see I'm out of the practice for a little bit here.
Because I think that is so effective to make sure that we don't bottom people out. To be quite honest, I used it in practice. I had a lot of colleagues who used it in practice. To basically to make sure we didn't keep bottoming someone out or get them up, which way we needed to go. Yeah. Low and slow is always my rule with everything, particularly insulins, because you can kill someone, and opioids and scheduled meds, because you can kill someone. So I always, and heparin drips. I'm always very mindful in blood. Those are kind of my 4 triple, quadruple cautions to myself.
Jill, I know you touched on this, but I'm just wondering if you can talk a little bit more about why it's so important to have patients get immunizations patients that have diabetes get immunizations.
And I think, well, it is absolutely, it's a guideline, it's important, it's, and the rationale is because people with diabetes in particular, immune system is down, because it's an endocrine problem. And so in that, particularly with the viruses, shingles, chickenpox, we have vaccinations against this. And what it's, it's not that chickenpox is the problem, it's what happens. The chickenpox, the sequelae of chickenpox then is infection, right? You have chickenpox, you're not vaccinated. Let's go down that path. So I'm diabetic, and say I have 3 other comorbidities, and I have chickenpox, not vaccinated. Okay, so I have a spot here. I have one, chickenpox, you can have 5 spots or you can have 10,000. But just say I have a mild case. I have one spot on my neck. I'm scratching. It gets infected. It doesn't heal. And then before you know it, and I'm not kidding, particularly if it's staph or strep rather, within 24 hours, you can be septic. And that's That's really why it's important. Streptococcal works much quicker than staph, insofar as spread. And it's going to be strep or staph probably anyway. You know, something you scratch, a mosquito bite, like it would be the same as a mosquito bite, same idea. So if we can prevent that, and not go septic and end up in the hospital, that would be great. You know? And I think it's also really important to just with diabetes, if someone has diabetes, typically, and this is from experience, it's not from literature, 95% of the time they have 2 to 3 other comorbidities. And so that's why it's a really head to toe, and it's the sequelae of so many things. So honestly, you typically don't just have diabetes unless it's really well managed.
Thank you.
I have a quick question around, because we talk about gestational diabetes as well. And facilities have been taking residents that are younger because of complications of, whether they were in a car accident or something like that, or there's some other debilitating that's causing them to be in a long-term care facility and they're pregnant. Should facilities look at how do they manage someone who is a pregnant mom within their facility, especially when it comes to diabetes?
It's really the same, other than your screening, because you're going to do the oral glucose. It's a 2-hour. It's not real fun for the pregnant woman. So your testing is going to be a little bit different. But insofar as your management, it will be about the same, exception for your category D drugs, which are you cannot give to pregnant women for your treatment therapies. I don't know them off the top of my head, but there are some that you cannot give that are in category D. But it's the same, managing their making sure their glycemic control is what it should be, with the allowed diabetic agents that can be used with pregnancy.
Oh, I'm sorry, go ahead.
Oh, sorry, Kim.
Please,
I was
go
just
ahead.
actually, it was a question for the group. I was just kind of wondering, we were talking a little bit earlier about, for maybe the residents who have been diagnosed with prediabetes and even those with diabetes. And we talk about exercise or diet. And I'm just wondering, is that a challenge in some of your facilities? That whole, we were talking about carbs a little bit earlier too, in the diet control for some of those residents. Just wondering any ideas anybody has on that, or how they do it in their facilities. Because and I could be totally off base, but just my experience too is that, there's not like there's not like a meal for a patient with diabetes. There's not a special meal for a patient with hypertension, or even special meals for patients with chronic kidney disease. So just wondering how you do that in your facilities. I always feel like I make the group go quiet when I ask questions. Well, and I do know too, from my experience too, a lot of times it's kind of been like the resident should maybe know what they can and can't eat, but I'm just wondering if there's any help for those residents.
I can say really quickly, because food becomes so important. I mean, food is important to all of us for our years, but it becomes more important when you're a resident and having a sense of control. And so being able to put it in some activities and having healthy initiatives has been helpful in homes that I was in. And making sure that the resident was able to control what that looked like, instead of saying you can't have something. So I found that helpful within a facility. So
I have to go with my Keisha a little bit on that. We used to like have different diets, like we would call them 1500 consistent carb diet, ADA diets, or 1800. And as time progressed, we did go away with those special controlled carb diets. It went with more general diets for the residents, just based on their what they want. Here's a balance, isn't there, on what they want and what's healthy, and that fine line of compromise.
I have a question. Um, you know, we spent, or at least I know we covered briefly on, trying to consider a patient's, lifestyle, their culture, their preferences. Do you have any advice for trying to customize or meet with the patient part way, I guess, if you will, and establishing a good plan of care that does meet their cultural and personal needs and preferences?
I mean, absolutely, because I mean, and I'll speak on this. I think you have to customize also your approach as a provider or family member, even as a support person, to help them get on board with the things they should be doing. I think the idea of, okay, we are pre-diabetic now, or we're diabetic, so we're going to take away the bread, the cookies, the this, the that, we're going to take away everything. And mom, or whoever it is, mom, brother, sister, aunt, uncle, your blood sugar is going to be 120 every day. That will not work. This is I have tried to do that when I was a novice, and the idea is it is not a one-stop shop. It is about what is super important to you. The one thing once a week that is super important to me is that I have dinner with my family on Sunday nights. And my sister makes, spaghetti, and she has garlic bread, and she has pies, and she has cakes, and she has all this stuff. And I am not going to miss that. And I'm going to eat everything there is, because that's what I do. You have to appreciate that and accept that. And we're not going to get through that Sunday dinner. That is what they're going to do. But let's look at the other 6 days. So what can we do in the other 6 days, maybe to give you a little pass on Sunday dinner? And then as time goes by with our planning and our patient-centered care, at Sunday dinner, your sister makes 4 pies, and you try every pie. You have a slice of every pie. Can we just do 1 pie? And maybe can she make it with Splenda? Oh, I never thought about that. So sister does that. Turns out I love that pie. It's my favorite pie, and I don't need those other 3. I mean, it's not a one and done. It is a team collaborative. What is important to you? I mean, food is particularly, and I can speak to my Bulgarian family, my brother-in-law, my sister, and my niece. Food that's culture, that's celebration. That's someone dies, we eat. Someone's born, we eat. Every holiday we eat. We just eat. But if you're diabetic, with all the bread and the musica and all the beautiful things, you don't have to neglect yourself, but you can portion control. Like 1 bite of something is not going to blow my glycemic control. But it's those sorts of things. But it's time and talking through and agreeing and making a plan. What are the negotiables? What are the not? Sunday dinner is not negotiable. Okay, we got to work around that. And that's how we move forward. It's not going to be perfect, is what I'm trying to say.
No.
Yeah.
We're running out of time, but I just quickly wanted to mention, I wanted to go back to that hypoglycemia question when we had Some of our audience indicate that, yeah, we have that. Yeah, that sometimes is a problem with in our building. Okay, here's your challenge. Why? Not just, well, yeah, they didn't eat. Okay, but why? What time did they, if they get insulin, what time did they get their insulin?
Right.
If it was too early, did they bottom out before they ate?
Right.
Are they sick? Did um the nurse miss get checking a blood sugar and then they didn't get anything to eat? I mean, I just want to go back to just the whole quality assurance again with diabetes, because I would look into in more depth on why someone is, we're going to call bottoming out all the time, or why someone is really high all the time, or maybe they bottom out and then like that 15-15 rule. The reason I brought that up was because nurses freak out sometimes and they're like, they're getting low. Oh my gosh, they're at 58, they're at 55. Yep, I'm going to give them that 15 carbs of orange juice, but you know what? We're going to put some extra sugar in there. And now you just gave the resident 50 carbs.
Sure.
And yeah, and in 2 hours later, they went 58 to 450. I've seen this. That's why I'm like, dig down to your reasons of why you have real highs and lows. It might not just be resident specific. It could be the way your system is, the way, how much education your nursing has. Do they fully understand what it means when you say long acting insulin? I held the long acting insulin. No, don't hold long acting insulin. No. So, I mean, these are things I know we can't get into, but Rachel's going, yeah, I know. Go back to your homes and like think about that. Think about those reasons for the highs and lows. Yeah, we have 2 minutes left. And what is kind of cool about this series we're having is Rachel's coming back again next week. This gives all of you some time, maybe to think about what I just said about go back and look at some of those highs and lows and come back not next week. Don't come back next week. We won't be here. Come back the week after that to like maybe discuss this a little further. Maybe you have more questions for Rachel. But Rachel, tell us again, will you be zoning in more though on in 2 weeks when you come back to talk to us?
And actually I will be present, but it's Tracy speaking. And this, because it's a two-parter, and her talk is wonderful, because the other big piece to all of this long-term care is that you get people from the home, you get people from the hospital, you get people from skilled, you get people from assisted living, you get people from wherever. And you might be plopped with someone who has diabetes and they have 10 different treatment plans because they've been at 10 different places, what to do. So she's really going to speak to the coordination of care, what really to look for, and
look at some of the strategies, barriers, that are out there, the challenges, common challenges that you might face.
And what you can do knowing that and kind of do a workaround basically. Yeah.
Sounds wonderful. Can't wait. That's good. All right. I think we have dropped the evaluation in there. If we haven't, Jerry, could you put it in there again? I haven't seen it. Doesn't mean it didn't happen, which I really appreciate if you could fill that out for us. We do have another question here. Will there be a discussion about, it went right past me. Sorry. What did it say? Will there be discussion about limiting the use of sliding scale insulin in a nursing home? I'm so glad you brought that up, Christy, because it was it was on my question. We couldn't get to it. So let's put that down there for next week. So maybe Rachel can just give us a little tidbit about that, because you're right. There's not a lot of sliding scale for the elderly anymore like there used to be.
And it is evolving. Guidelines are changing, trying to get sliding scale out of the hospital. It's kind of in flux a little bit right now, but happy to speak to that after maybe Tracy's talk in 2 weeks. You can speak to it even. But yes, of course, yes, sliding scale. Yeah, I hear you. Thank
Yep.
you for that, because that is a great
Good one.
topic of discussion.
Okay, everyone, we're a minute over. I want you to be able to get back to your day. So I appreciate your time and appreciate the speakers today, because it was Rachel and Nicole and the whole team and Tracy. Appreciate you all. We'll see you in a couple of weeks. Bye, everyone.